So we need to be more authentic with each other.
Whole life, physically, mentally, and spiritually.
Christ, Jesus, the great physician. And he was healed, and now
It's really time to reconnect with your family.
All about life, health, and healing hope. Whether we're talking about life or your health, it's all about healing hope right here in our telecast today, and we're so glad you joined us. You know, Jeannie, the emergency room is kind of a place of apprehension and concern to many, many people. Think about fire engines and sirens and ambulances. But really, an emergency room, in our lifetime experience, I've had my share of trips to the emergency room, almost cut off a finger once, putting it through a glass of the garage door window. You've had your experience in emergency rooms. Very, very often, these are places of really healing hope for people, and they help put us back together again.
Yes, I think a lot of people are so fearful because they don't know what's going to happen. You know, their life is at stake, they've had some emergency, so it's very scary to them going into the emergency room. And I remember when I had a snow skiing accident and broke my wrist on Mammoth Mountain in California. And they wrapped me all up, cut my jacket off, and took me to the emergency room. I will never forget how effective those nurses were in calming my fears and making me feel better by just hands-on. They would touch me, they would rub my arm until the surgeon could get there and could explain to me. He said, you know, Jeannie, he says, this is the worst wrist break I've ever seen. He says, you have the compound fracture, the ulna and the radius, and you've crushed all your carpal tunnel bones. So we have a lot of major work of screws and wires and even bone grafting. But you know, that was so good for me to hear, because he took away, and the nurses took away, all the fears of the unknown so that I would know what to expect. And so I really appreciated the emergency room.
Very affirming.
And speaking of emergency rooms, I think our viewers are really going to enjoy today's show. Dr. Becky Wong is going to guide us as we get a look inside what life in the emergency department is like. We'll also learn what you can do as a patient to make your visit there as pleasant and effective as possible.
I'm on location today at Kettering Medical Center Emergency Department. I'm here with Dr. Keith Goldblum, the Chief of Emergency Medicine. So delighted to have you here with us today.
My pleasure.
There are so many TV dramas and movies that feature hospitals and emergency rooms. How does what you do here in the emergency room differ from what we see on TV?
Dramatically, if I may use that pun. In TV, they're cutting everything down to the barest essential, most dramatic moments. It's not always that way. The drama goes from the front door to the operating room in one movement, and that's not reality. It has people do come in through the front door or through the back door, through the ambulance entrance, but need to be assessed, put into a bed and a gown and all the banal type of activities that they don't want to show on television. But there's a process.
Keith, you've been in emergency medicine for almost 30 years. What attracted you to this kind of environment that sometimes can be really high pressure?
Well, I like the pressure. That's one of the things that attracted me to this, and the variety. We never know what's coming in the front door or the back door. It can be minor illness, it can be major trauma. So that sort of thing keeps me on my toes and keeps me active and interested. Plus there's a wide variety of illnesses and conditions that I have to deal with, which is also exciting. So I see everything from newborns to the most elderly, pregnant patients to trauma patients.
Do you think it takes a special kind of physician or nurse who chooses to work in the emergency department versus a 9-to-5 job in a physician's office or on the hospital floor?
Oh, very special, very special. An internist came to me once and said, I don't know how you can stand not knowing what comes in the door. And I turned to him and I said, I don't know how you can stand knowing. The same thing that makes it exciting also makes it a unique challenge. That is, we don't know what's happening, what's going to happen through the door the next minute. The patients may be critically ill, maybe not, or come in not critically ill and become critically ill. So it always keeps us on our toes. The personalities that don't relate well to that aren't going to last long in the emergency department.
Do you feel like you can form a relationship with a patient that you may see for 15 or 20 minutes and maybe once in a lifetime?
Actually, yes. We have a unique opportunity to talk on a deep level in some instances with a patient for a very brief period of time. They're here to talk to us, and sometimes it's a social conversation. It can be a very intimate conversation about their own medical problems and history.
Well, that actually brings up a good point. Tell us about how you deal with patients who come in who have tried to commit suicide from overdose, and you have families that are distraught.
Well, that's a unique challenge because there's a lot of emotion involved. And it takes a lot of calming of one's own emotions before going in and talking to people. There may be anger, certainly depression. There may be as much emotional upset on the family side as it is on the patient side. So we have to integrate those and sometimes separate the parties and sometimes bring them together. It's unique because we have to sense the moment, each one being individual.
Do you have chaplain support in the ED?
We do have chaplains, and they are. I've never worked in an institution outside of Kettering that had such good chaplain support. Most hospitals have a chaplain, but the chaplains here are also concerned about the state of the staff, and nobody is inhuman. We're affected by what goes on around us.
I'm sure that our viewers out there would like to hear directly from an ED physician with all that experience. What's the best way to prepare to come to the emergency room?
Well, I think that what is important for the emergency department staff is to know exactly what it is that led you to come here in the first place. Sometimes people have multiple conditions, but not all of them emergent. It's important to try to identify the one particular or two particular conditions that one is most concerned with, and try to understand or delineate the things that led up to that condition. A list of medications is important, or the medication bottles themselves. Some contact numbers, if you can't come with your family members, at least have somebody that we can contact for further information or to just notify about your whereabouts.
Let's say it's something really traumatic, like they've cut half of their finger off. What should they do with the other half?
Well, the current recommendations for that is put that finger or body part in a plastic bag, a sealed bag, and then put that on ice.
So don't put the finger or body part directly in a cup filled with ice. Seal it off.
That's less desirable, let me put it that way. But the ideal is to seal it off and then put it on something cool, keep it preserved, and hopefully clean. And of course, the remaining stump, treat with pressure and bandages and elevation.
Now, some people wonder, is this really an emergency? Should I just call my doctor and try to get into the office today? What are the conditions that you would recommend that a person come directly to the emergency room for?
Certainly, any significant form of trauma, chest pains in those who are susceptible to cardiac disease. And if you're curious or don't know, then it's better to err on the side of caution. Severe shortness of breath, an unusual or severe headache, loss of function of one body part or other, or vision. Those are things that we need to see right away.
And how is it best to come? Should those conditions you mentioned always come by ambulance, or should they, if they think that they have a car, should someone drive them?
Well, certain conditions I think can be handled with one's own car, and that has to be the individual's best guess as to their safety. and the safety, of course, of the person driving them and the people on the road. If there's any concern with that, if there's a sense of immediate injury or deterioration, by all means call the ambulance.
Is there any truth to the fact that if you come by ambulance, that the doctor will attend to you sooner rather than if you come in a car?
Well, I have to tell you, we're on to that. So if you do come by ambulance and you're really not an emergent patient, we'll have the ambulance personnel bring you right to the front of the department and out to the waiting room where you'll register with the rest of the patients.
And what about that whole process of how you determine what patients need to be seen very soon by the doctor and others that can actually wait because they're not as seriously ill?
I'm glad you asked that, because people who come to the emergency department and see somebody else who's taken before them oftentimes are a little bit irritated, thinking that they were there first. But it's not a first come, first serve. We do have a system of triage, and our nurses and our emergency personnel are very well trained in that, as well as the physicians, of course, to determine what conditions and what vital signs and what complaints might take precedence over another.
We'll have more Healing Hope after this brief break.
Over a century ago, a brilliant young Dayton inventor had a vision for the future.
By itself! You know, this Kettering guy just might change the world.
Today, that same spirit lives on at the Kettering Medical Center Network, bringing the best in medical technology from around the world home to Dayton. With that kind of vision for the future, what might tomorrow bring?
Those guys just might change the world.
You can only imagine. The Kettering Network, for life.
If I'm going to be a healthcare provider and if people are going to come to me and trust me, then I want to give them the best care that I possibly can.
I love it. It's great. The classroom sizes are awesome. You get that personal one-on-one time, even in class.
They taught well, and I learned well, and they really truly cared.
The philosophy of Kettering College of Medical Arts is such that our view of who we are as people means that when we care for others, we are doing the work of God. We are God's hands.
It was just so surreal to me because I didn't ever think I had a heart problem. You know, here I was 47 and they said that, you know, I probably had about a 1% chance of making it. And I did. Kettering is known as the heart hospital, and when I see Kettering, I think that's where I got my second chance, and it feels like home.
For more of the story, go to experiencekettering.com. Kettering, for life.
I knew it was serious the whole time, but it was still just unreal, and you never really soaked it in. So I was hearing all this stuff, and it sounded really bad. You can't even tell that she went through such a crisis because she's back to normal, and they said she'll eventually feel better than she did before. So I don't think they realized that they not only saved my mom, but it helped save my family.
For more of the story, go to experiencekettering.com. Kettering, for life.
Welcome back to Healing Hope. Now we rejoin Dr. Becky Wong and Dr. Keith Goldblum as they discuss life in the emergency department.
Now we know that there's been a lot of talk about certain conditions like a heart attack or a stroke where time is of the essence. Can you tell us a little bit about the process with any of those?
Well, if somebody comes in with stroke symptoms, loss of control of one side of their body, for instance, we have a window of opportunity to give them medication to minimize the amount of damage to the brain, just as with heart attacks. If we get it within that window and we get the medication, and there are certain criteria, of course, let me add. I mean, some people don't fit the right criteria. But if the conditions are right, we can minimize the amount of damage and therefore the amount of long-term illness associated with that stroke.
So the message for the audience then is if they feel like they might be having any question of heart attack or any new neurologic symptoms, they need to come immediately, and you will respond immediately to be sure the right treatment.
That is exactly right. If they delay, then we may lose that window. And if they're within just minutes of that window, the criteria that are set up are such that we might not be able to intervene. Then they may have a permanent dysfunction.
And it could be reversible if they come soon.
If they come soon, yes. And the same is true with heart attack. We may not save every cell of the heart, but our goal is to minimize the amount of damage to the heart wall and therefore minimize the long-term cardiac implications.
I know that sometimes you get patients directly from a nursing home, or let's say it's a special needs child that takes ill at school, and the parents are notified, or the family members, and they can't get there immediately. How do you deal with someone who comes in and is nonverbal or is not able to tell you where their pain is?
We try to combine a number of inputs from the nursing home staff, from the medics report. We try to integrate with the patient themselves in a variety of ways. I have a form here to show you that we may ask them to point to a glove, for instance. And if they can do that, then even though they are nonverbal, we know that they are able to receive what we're saying and communicate with us. So we try to use the different ways. With children, we use a pain assessment scale, try to look at them and try to interpret based on their facial expressions what amount of pain that they're in. Then the final pathway that we use is the physical exam itself. And we'll start at the top and work our way down, or whatever process each individual physician uses, but to try to uncover the area where the pain is.
Keith, after 30 years, I'm sure there are some cases that still stand out in your mind.
Well, there are some exciting cases that where you get a nice, good feeling type of reward from. And a number of years ago, I helped deliver a baby that was a near-term baby and a mother that had died. And the baby survived, and the father wrote me a couple of years later with a picture of the child, just to say thanks. And that was a nice highlight.
How often do you have deliveries that are maybe in the ambulance already or in the car, and then you have to actually do it in the emergency room?
Well, fortunately, those are fairly rare. Now, I've had to deliver them in the taxi out of the front door. Mm-hmm. And on occasion, they come into the emergency department ready to deliver. Fortunately, most of the time, those go very well.
That's good.
Fortunately, the body is designed to do that, with or without us.
That actually gets to another question. I'm sure people are curious about exactly what is an emergency room physician trained to do in the ER itself.
Well, we're trained in the broadest sense in the emergency aspects of almost every specialty. So a child with a high fever, a dislocated joint, you mentioned an amputated finger, headaches, strokes, heart attacks.
Well, let's go back to the dislocated joint. Let's say the shoulder is out of place from wrestling. Do they have to go through an orthopedist's office, or can you deal with that?
Well, 9 times out of 10, they're not able to get into the orthopedist's office on that kind of acute setting. Mm-hmm. And that's not what they're designed, the orthopedist is designed, his office is designed to do. We are. So they come to us, and the majority of the time, we can replace that joint back into place, mm-hmm. What we call reduce the dislocation, and then refer them to the orthopedist afterwards.
So you don't have to take them to the operating room for that?
Majority of time we don't.
Is it real painful?
Well, we give medication to deal with the pain and medication to help sedate the patient so that they're not really aware, certainly don't remember any of the procedure.
So they can be in and out in a matter of a few hours?
In a matter of a few hours, they can be in and out.
Speaking of in and out, what is the usual expectation if someone comes in with a really acute problem? Let's say they've had a bee sting and they, their airways closing down, versus someone who comes in with abdominal pain that they've actually had for the last 3 days. What's kind of the time frame?
Well, the more acute the problem, the more rapidly the patient is seen. That's part of our triage system that we talked about before. And if it's a bee sting, for instance, we're going to see that person right away because it's a threat to their airway and therefore their life. But fortunately, the agents we use to reverse that problem are fairly quick acting. And the patient may only be here a couple of hours. If they are effectively reversed and their vital signs are stable, we can let them go home. The abdominal pain usually takes a little bit more of an extensive workup, more things to look at, more things to consider to find out the...
And maybe a CAT scan that may take some time.
The CAT scan takes fairly short, the actual procedure for the CAT scan, but getting a person ready for the CAT scan, getting the CAT scan read by the radiologist, all that takes a little bit of time. So there is a workup involved. And in this day and age, more and more of the diagnostic workup is being done in the emergency department. So the delay in care, or delay in the actual disposition, we call it, or going home or being admitted, is there. It takes a few hours sometimes.
What would you recommend for someone who has not a seriously acute problem? Is there a better time of day to come so that they won't have a long wait?
You know, people have been trying to figure that out for the longest time. And I think no sooner than they think of the right time of day to come to the emergency department, that's the time that everybody else has thought of too. So we try not to even give an estimate of time if somebody calls in and asks, because we don't know. At the moment they arrive at the door, we may have 3 ambulances come in.
That's the unpredictability.
This is the
that
unpredictability.
you talked about, yeah.
That's right. So we hate to even try to anticipate what would be a good time and what would not.
Well, Keith, this has been so informative for our audience. And one last thing I think we should cover, the patients that are not admitted to the hospital that go home, what's the whole discharge process?
I think it starts with trying to inform them of, in the emergency department, a lot of times we don't arrive at a specific diagnosis, but we have a general diagnosis, and more importantly, we have ruled out the major problems that would be a life or limb threatening issue for them. That being set aside, then we urge them to follow up with their physician for further care or further diagnostic workup for that problem. Ideally, we made them 100% better. But we give them this information in a packet with the name and address and phone number of the physician to whom we're referring them, whether it's their own doctor or a specialist, and a way to get back to us if problems continue or worsen.
What about their test results?
Now, we don't actually hand them the actual written results. We go over those results with them, but we do send those results to their primary physician.
Thank you so much, Dr. Keith Goldblum. It's been very informative. We've all learned a lot today.
Thank you.
We'll have more Healing Hope after this brief break.
They actually do care about your progress. I know, when I heard that I said, yeah, okay, you know, you hear that from a lot of schools. No, really, we do care about your success.
When I go home, I talk about Kettering because I've had such a great experience here.
If you have a commitment to going into healthcare, you're going to get there in a setting where you know your fellow students and where you know your teachers, and it's going to make you someone who I think is going to be really highly valued in the workplace.
Never again just take anything, the perfect pregnancy, for granted, because you just never know. We were 4 weeks to the day early. I immediately was just like, we can't do this. We're not ready, you know, he's not ready. The special attention there was from the get-go. And so I knew he was going to be in good hands because it was their child, in the sense that the comfort was just there.
For more of the story, go to experiencekettering.com.
He smiles all the time. He's just, you know, thriving. Loves his mommy and daddy.
It was just so surreal to me because I didn't ever think I had a heart problem. You know, here I was 47 and they said that, you know, I probably had about a 1% chance of making it. And I did. Kettering is known as the heart hospital, and when I see Kettering, I think that's where I got my second chance, and it feels like home.
For more of the story, go to experiencekettering.com. Kettering, for life.
I knew it was serious the whole time, but it was still just unreal, and you never really soaked it in. So I was hearing all this stuff, and it sounded really bad. You can't even tell that she went through such a crisis because she's back to normal, and they said she'll eventually feel better than she did before. So I don't think they realize that they not only saved my mom, but it helped save my family.
For more of this story, go to experiencekettering.com. Kettering for life.
A trip to the emergency department is nearly always an unexpected event. And when our health takes an abrupt turn through an accident or illness, well, it can be a frightening time. I know from personal experience that the skill and compassion of emergency department professionals helps to calm those fears. God does wonders through His people. It's reassuring to know, however, that no matter where we are, no matter what our circumstances, God reminds us in Isaiah 41:10, "So do not fear, for I am with you. Do not be dismayed, for I am your God. I will strengthen you and help you. I will uphold you with my righteous right hand." God is with us always, at work, at home, and when life takes an unexpected turn. Just remember, when a friend or loved one is going through one of those difficult times, that may be an opportunity for you to reach out, to comfort, to be the presence of the Savior in someone's life. It can make all the difference in the world. Thanks for joining us today. For the Kettering Health Network, I'm Lonnie Melashenko.
Next time on Healing Hope, Lonnie spends some time with filmmaker Martin Doblmeier talking about his documentary, The Adventists, which explores body, mind, spirit connections and the health message of the Seventh-day Adventist Church.
Now, you focused on several Adventist healthcare facilities. Was there any kind of a common thread that you found, whether it was in Florida or Loma Linda or here at Kettering?
Well, I think commitment to mission. I think I saw again and again that there was a genuine focus on what the purpose of the healthcare effort was, and that it was centered around the appreciation that hospital work, healthcare work is sacred work, and that caring for the body is, when you're caring for the body, you're caring for the temple of God.
And later on, we'll learn about the warning signs of cancer.
You are the most important early warning system. By knowing the signs of possible cancer, you will know when you need to seek medical care in order to receive an accurate diagnosis and early treatment.
Coming up right here on Healing Hope. See you then.